You all. Thanks for joining us. For those of you who don't know me, I'm Isabel Pereira. I'm an assistant professor of government. So thank you to the sociologists for letting me crash your territory. And thanks for the Institute for European Studies for sponsoring this seminar with Alex Barnard, who's assistant professor of sociology at NYU. Professor Barnard works in medical sociology, political sociology, comparative and cultural sociology, social policy, and social theory. He earned his BA from Princeton, his master's from Oxford, and his PhD from Berkeley, all with a number of distinctions along the way. He has written 2 books and has one forthcoming, which is what we're going to hear about today. Freegans, published in 2016, examines the sociology of dumpster diving in the US. Conservatorship, published in 2023, examined the sociology of California's coercion and care for the mentally ill. And mental states, forthcoming, compares how France classifies mental illness in light of kind of the American perspective as well. This and other work has been published in Columbia University Press, University of Minnesota Press, the American Journal of Sociology, Social Problems, Theory and Society, many good places. He's going to tell us more about this next project that's coming out hopefully later this year.
Yeah.
And it's a great pleasure to have him here with us. Alex, I'll turn it over to you.
Yeah, thank you all very much for coming out. I realize I'm the only thing between you and the weekend, probably. So I am really grateful you're here. Thanks, Isabel, for the invitation, Patricia Young for the generous support from IES, Aidan Kelly for the logistical legwork. So what I'm going to present to you today is from my forthcoming book, Mental States. It's part of, as you said, kind of a 2-book series in which I examine the trajectories of people with serious mental illness between state institutions of care and control in France and the United States. So Mental States focuses in particular on the contemporary consequences of the way that the French state decided to define, categorize, and govern mental illness subsequent to the closure of large public asylums in the mid-20th century, commonly referred to as deinstitutionalization. And more subtly, it's about how the people constructed as the mentally ill push back on that category, reshaping social policy itself. So this talk is going to be organized around analyzing a tension that confronts any mental health system today. How to give people with serious mental illness a modicum of independence and self-direction in their lives in the face of the challenges posed by chronic illnesses. And to understand the distinctiveness of how this dilemma poses itself in France, it's helpful to start across the pond here in the US. So the images you see are various scenes documented by myself or journalists of the crisis of homelessness, substance abuse, and mental illness on the streets of California. And as part of several years of fieldwork, I shadowed a community paramedicine team in one coastal city. This team was assigned to try and provide for some of the most vulnerable individuals in this area on which almost all other public agencies had given up. So we visited a homeless woman who, after several years of contact, still had refused to give her name, and for whom passersby kept calling 911 because of gaping sores on her arms and legs. We spent some time trying to convince an alcoholic with serious dementia who had wandered away from his homeless shelter to go back, as well as visited a supported housing complex where a floridly psychotic man was living in a tiny room covered in rotting food. I was struck in all of these cases by the near complete absence of the public mental health system in these people's lives. Derek, the paramedic who served as my guide, told me that they called the county mental health department every day, quote, to wear them down, but were always told these individuals were too sick or too resistant to serve. Every once in a while, this system leaps into action. So we received a 911 call about somebody who had deteriorated to the point where he could be subjected to an involuntary examination to be hospitalized. Derek turned on the sirens, I think mostly for my amusement, and we sped across the city to a dilapidated single-room occupancy hotel. When we went upstairs, 3 firefighters had beaten down the door, revealing a tiny room where a gaunt man with a yellowing beard was splayed out on a tangled mass of sheets. Derek snapped on a pair of latex gloves and told the man, "You're coming with us." The man accused him of spying for the FBI and of kidnapping, but we took him downstairs and loaded him into an ambulance to take him to the county hospital. A few months later, I did a follow-up visit in the city and asked the paramedic what happened to the man. He looked him up in the city system and told me they kept him for 2 days and then they dumped him. He was evicted from his hotel, and the last time they found him, he claimed he hadn't eaten in several days. Not a happy ending, I posited. No, not a happy ending. This is indeed the sorry story we have heard many times, that in the United States, the mentally ill were released from hospitals only to be transferred into homeless shelters or jails or completely abandoned on the street. It is paradoxically a system that leaves many mentally ill people a kind of bare autonomy. The system offers little to address people's illnesses, and instead, outside of moments of coercive intervention, like this man's 2-day hospitalization, it largely leaves them alone. This anecdote captures a core tension. Across the Western world, states face a cultural and policy mandate to promote independence. Yet conditions like schizophrenia have a medical and social reality of chronicity that often leads to dependency. Our case study here is the story of this people with serious mental illness in France, who the French often referred to as malades, where this dilemma has presented itself in an almost obverse fashion. So in France, reforms to the public mental health system in the mid-20th century envisioned a population of chronically ill people who are completely dependent upon a paternalist psychiatric system that would expected to meet all of their needs. This talk is going to analyze an attempt to change that. So in 2005, a reform to France's disability system sought to reclassify these people who were labeled as malades as people with a psychic handicap and render them more independent by transferring some of their care out of the health system into a parallel system serving people with disabilities. So my theoretical framework for this book draws on the work of the late great philosopher Ian Hacking. So Hacking was a theorist of science and medicine who studied the elaboration of what he called human kinds, population categories like alcoholic or dependent poor that experts fabricate in order to provide principles through which they can treat, discipline, and try to improve problematic populations. In my book, I talk about malade or disabled person as examples of two bureaucratic kinds. That is, categories used by the state that are not just administrative labels, but entail a set of expectations of how these people will interact with state agencies, use welfare benefits, and develop over time. Hacking's analysis is dynamic because of what he calls looping effects. As he shows, people who are placed in a certain category inevitably respond to that categorization in unexpected ways. So for example, in the case of autism, the broadening of the autism spectrum has meant that many individuals who we would define as high functioning have now entered into that category. And this has enabled them to mobilize to demand a reclassification of autism from a disorder to a valued kind of neurodiversity. I'm going to extend this analysis to the state, as I will show the unexpected ways that people with mental illness responded to the label of disability ultimately forced modifications to the intentions of policymakers and the practices of professionals. So by way of a roadmap, I'm going to start by elaborating a little bit the contrast between France and the US. I'm then going to talk about my methods before moving into two empirical parts of this talk. So first, I'm going to talk of kind of at a historical level about the career of this category, psychic handicap. And second, I'm going to take you to a welfare office in France where bureaucrats struggled with this question of how to transform the mentally ill into this new category of disability. So this theoretical framework helps us understand the divergent consequences of deinstitutionalization in France and the US. So as of the mid-century, as you can see here, the United States actually had more psychiatric hospital beds per capita than France. And in fact, at their height, there were 550,000 Americans in psychiatric hospitals, an enormous set of institutions. In both countries, optimism about new medications and community care, combined with exposés of poor hospital conditions, led to calls for a new model. And particularly in the US, the federal introduction of Medicaid and Social Security disability created possibilities for states to shift costs onto the federal government, which drove the closure of 90% of state-run beds in ensuing decades. However, the federal government never actually created anything that we could call a kind of system. As a national report in 1980 concluded, persons disabled by chronic mental illness have been victimized by a lack of consistent national policies for planning, coordination, implementation, and funding. The authors elaborated for the first time a national plan for the chronically mentally ill. Under Ronald Reagan, however, the plan was never implemented. You do a presentation on American social policy, you have to throw in a dig at Ronald Reagan. So there you have it. So in effect, the most seriously ill in the United States have no true bureaucratic kind. That is to say, to be chronically mentally ill in the US is not actually an identity in the eyes of the state. You might receive housing if you're classified as chronically homeless. You might get medication in jail. You might receive a minimum income based on a finding of disability, but the identity of illness in itself does not unlock access to any set of programs in particular. As you can see in France, deinstitutionalization was much slower, and today the country has 2.5 times more hospital beds per capita than the US. More importantly, in my view, however, is that French policymakers gave a much stronger bureaucratic identity to the people who were slowly leaving hospitals. So rather than dividing responsibility between different agencies in the US, in 1960, France inaugurated a system called sectorization. Under it, France would be divided into territories of around 70,000 people. And under each territory, a single psychiatric team, as you can see here, this is the circular, establishing this would be responsible for assuring for all malades, screening, outpatient treatment, hospitalization, and social reinsertion. In short, French policymakers envisioned a single population, malades, having their needs met by a single institution, the sector, which would be dominated by a single group of professionals, psychiatrists. As I'm going to reiterate throughout the talk, the system was at once protective and paternalist. Sectors offered ongoing solidarity, but very little in terms of a future of independence. So the book is organized around following people in this bureaucratic kind of malades as they are processed through different wings of the state. So I start by analyzing how clinicians in the health system navigate the expectation of providing treatment in a context of economic austerity. I then look at the disability system and this tension between promoting autonomy and addressing chronicity, before moving to the judicial system, where we see how judges and lawyers decide on involuntary treatment for malades who are trying to escape contact with the state, which requires a delicate balancing of care, rights, and social control. In each of these cases, we see how the unpredictable responses of malades to being classified, disciplined, and coerced can stymie the effects of policymakers and professionals. My argument is that these looping effects are part of what reproduces a distinctively French approach to mental illness, despite the fact that best practices, treatment, and formal diagnostic categories for mental illness have largely converged worldwide. Mercifully, I'm not going to try and cover all of this today, but just focus on this middle part. So most of the data for this talk were conducted as part of my dissertation in 2015, 2016, with subsequent follow-up visits. Grad students, we can talk in Q&A about the hazards of trying to publish data that is now 10 years old. Time flies. But also in some cases, how a few years of distance can be helpful in actually seeing whether our predictions about how a reform is going to turn out, whether those actually pan out. So one core set of data come from doing too many interviews. So I interviewed 193 professionals, advocates, and policymakers across different wings of the French state. And you can do anyway. I also rely on a variety of archival materials from the Ministry of Health, newspaper coverage, and administrative statistics compiled from the French government. Today, I'm going to focus in particular, I did multiple observations in multiple sites, but today I'm going to focus on my observations of a disability office in Paris, which handles tens of thousands of applicants who are requesting disability benefits each year. So I sat in on interviews with applicants, meetings where evaluators made decisions, the committee which handled appeals and from denied beneficiaries, and trainings for professionals. And I used this to construct a data set based on 296 benefit allocation decisions. In addition to coding information on demographics, medical situations, and determinations, I also developed categories that allowed me to try and capture some of the different justifications that professionals evoked for their decisions. As you're going to see, some of my core findings emerge from this kind of coding, which is that the team used very different logics, very different styles of reasoning when evaluating demands from people with mental illness versus individuals with other kinds of disabilities. Okay, part one. So in this part, I'm going to talk about how the French state reorganized its system for classifying human difference. This part of my analysis is in line with studies like that of Christina Mora on the fabrication of the category of Hispanic, or Mara Loveman's work on how the social significance of race is partly a product of how states decide to define and count different populations. This case is particular, though, because it's about the shifting relationship between two categories, mental illness and disability. A quick translation note, there's actually only one word in French, which is handicap, which can be translated as both handicap and disability. This may or may not be a clear way of dividing this, but I'm going to generally talk about disability, to talk about the disability system and the broader population of people with disabilities. And I'll use handicap to talk about this very specific category that gets generated in this period, which is psychic handicap. So, as I've already stated, the French psychiatric system, as it was created in the 1960s, envisioned putting a host of different forms of intervention and institutions together in a single administrative unit, the sector. Now, in theory, sectors will provide for all of the needs of malades through outpatient clinics, inpatient hospitals, day programs, specialized departments, and social services. And my interviews with psychiatric professionals highlighted this vision. So one psychiatrist told me, our vision of the sector is a bit totalizing. We did everything. The goal is to handle housing, social integration, rehabilitation, constructing a family, all of that, but in the health system. As two nurses told me, one of them kind of describing her role in supporting patients in everyday life told me, we are nurses specialized in assembling IKEA furniture. Another said, when I go with a schizophrenic person to buy shoes, that's a form of providing care. Again, in short, sectors envision themselves as serving a chronically ill population, which would be dependent on them for life. Indeed, many professionals told me proudly, quote, we never close a file. We provide care for life. And this is a pretty stark contrast to virtually any public service in the US. The sectors emerged in a post-war period where the French state was focused on building a welfare state organized around male breadwinners and an education system for ideal, which is to say normal, French children. It therefore largely relied on independent initiatives to care for more marginalized groups. So psychiatrists created their own system for malades. Parents developed residential schools for what was characterized as maladapted children, while charities created retraining centers for invalid workers or mutilated veterans. In 1975, the state sought to rationalize, unify, and provide public funding for this system by creating, in the words of the minister, a true social status for the disabled. I will note that it's not actually totally intuitive that mutilated veterans and maladapted children should be grouped together, and some proposed adding malades to this bureaucratic kind. However, psychiatrists' opposition to this was ferocious. So the head of the Union of Hospital Psychiatrists said that putting psychiatric patients in residential programs for disabled people was segregation, apartheid, and a new ghetto. This opposition reflected very clear corporatism, so public psychiatrists didn't want their funds transferred to the disability system. But it was also based on an ideological vision that chronic illness required active medical treatment in a way that disability did not. So one psychiatrist told me, the disabled is a person who doesn't need care, but just needs some help in a bed. And the idea that we're not going to treat these people as mentally ill anymore, you take away the medical dimension, that's intolerable. So psychiatrists largely won the debate. So the ministry recognized that in a reform that was designed to kind of cover up holes in the French welfare system, there was no need to incorporate psychiatric patients because they already had an institution, the sector. So starting in the 1970s, mental illness and disability, which in the archives previous to that are totally mixed up, became kind of mutually exclusive terms talking about two distinctive populations. So this triumph of psychiatry was short-lived, however. In the 1980s, economists in the Ministry of Health began calling increasing attention to the prevalence of long-term inadequate hospitalizations. I spoke to a consultant who conducted a study showing that 1/4 of hospital patients in France had been there for more than a year. So psychiatrists claimed this was simply an inevitable result of a chronic illness, but she came to a different conclusion. She told me their ongoing hospitalization was a product of the health system. That is, for those who were the most trapped in their schizophrenia, we weren't offering them any possibilities, any life experiences that would allow them to develop social competencies and to live in an ordinary milieu. It was the form of our medical response that was making them deficient. This is a very Goffmanian insight, if anyone has read Asylums, the idea that the institution itself is what fabricates chronicity. And it's worth noting how completely opposite the debate in France at this time was in the US. So while in the US, commentators were worried about mentally ill people being abandoned in the community, here the concern is about that same population being abandoned in the backwards of hospitals. Different trajectories of deinstitutionalization had created an entirely different equilibrium between chronicity and autonomy that shaped subsequent debates. More broadly, this was a moment where the state was recognizing that classifying people as a patient is about the most expensive way to deal with the population. The state thus wanted psychiatry to refocus on more classical medical interventions, like prescribing medication, rather than going with patients to buy shoes. So as one ministry official told me, with sectorization, psychiatrists said, we can do everything, we should do everything, we can do everything, we can find housing, find work, except that today the sector doesn't know how to do everything. It no longer has the means to do everything, and so it needs to work with others. As you can see in this graph, hospital beds closed dramatically in this period, that's the dark line on the top. Beds or places in a whole variety of different institutions serving people with disabilities, like nursing homes, supported housing, or protected workshops, opened quite rapidly. In this changing environment, it was parents of people with mental illness who took the role in demanding reform. They could see that resources for their children in the health system were dwindling. Some parents tried to band together to create things like employment programs for their children, but they couldn't get funds from the disability system because mental illness was not classified as a disability. In 2001, the parents' movement released a white paper that stated that their goal was to, quote, make exist the population of people suffering from psychic troubles in the community and inform the collectivity about the true nature of the rights of these psychically handicapped persons. To me, it's really striking the kind of constructivist language here. They were actually trying to create a new population in the eyes of the state that did not already exist. Yet it's also amazing how arbitrary this category was. So in French policy, mental handicap was already taken to describe people with intellectual disabilities. So the parents had to come up with another term. They used the Greek root psychic. Nonetheless, this category caught on. You can see from this Google Ngram that this term psychic handicap essentially did not exist until 2000. And then it spiked when it was inscribed into law in 2005, which is where we're about to get to. Importantly, though, parents were trying to hitch their wagon to a bureaucratic kind disability whose meaning itself was changing. So in the 1990s, French disability activists argued that the country was failing to meet its international obligations, including the 1996 European Social Charter, under which signatories were supposed to guarantee to disabled persons the effective exercise of rights to autonomy, social integration, and participation in the life of the community. And for example, people in wheelchairs blocked metro stations and roadways to denounce the absence of accessibility in the transit system. In the face of this pressure in 1999, the Secretary of State for Disability began the process of designing a new law. And she started with the assumption that, quote, disabled persons can only exercise fully their citizenship under conditions of a maximum restoration of autonomy. So in 2005, these mobilizations culminated in the Law for the Equality of Chances, Participation, and Citizenship of Disabled Persons. It officially defined disability as a limitation of activity or restriction of participation in life of society experienced as a result of alterations of physical, sensorial, mental, cognitive, or psychic functions. So many advocates I spoke to were really convinced that this was going to be a revolutionary change. So one mother in an advocacy organization explained, we talk about deinstitutionalization, but in the reality, the mentally ill were still stuck in the psychiatric institution, even when they lived elsewhere. They depended on psychiatry. They remained in the health system. Psychiatrists have a hard time talking about people. They can only speak of malades, their patients. She went on, the law of 2005 made the mentally ill for the first time citizens with the rights of other citizens. For these citizens, everything around housing oneself, feeding, having pastimes, accessing nature, social integration, and work, they are going to be accompanied by professionals who are not from the health system, not psychiatrists, not nurses, but social workers and educators. A destigmatization campaign shortly thereafter captured how people thought this new label would really change the social statute of people with mental illness. So these posters depict people doing somewhat stereotypically French things, buying a baguette. And one of them, they say, one of these people is psychically handicapped. So what? Advocates thought that disability could be a respected identity in a way that malade never could be. So Pierre Bourdieu, writing about the state in general, but certainly with France in mind, argues that modern states are able to fabricate both moral conformity, which he calls agreement on a certain number of values, and logical conformity, which is to impose the same categories of thought, perception, of reality. So psychic handicap achieved a kind of moral conformity. So one psychiatrist compared the resistance of psychiatry in 1975 to their acceptance of reform 30 years later and said, look, it was clear to everyone that the future was in the disability system, and we joined with the parents. I don't hear anyone saying anymore, we're not going to dump our patients on the disability system. But this new system was not just, too early, jumped the gun. This new system was not just a matter of a single classification, but a case where the state needed to see double. That is to say, people with mental illness were supposed to simultaneously be patients served in the health system and disabled people being rendered autonomous in the disability system. A cartoon that was put out by a disability association kind of inadvertently makes this potential contradiction clear. So on the left, we see the vision of somebody getting tied up in a psychiatric hospital. And on the right, they're achieving personal fulfillment in the disability world. But this is the same person. So the rest of the talk is going to focus on this question of logical conformity. That is, could the French state see the very same people as belonging to two different bureaucratic kinds? I'm going to take a drink. So I'm now going to pivot to the ethnographic part of my talk. So this 2005 law that I've been talking about, it created a new institution, the Departmental Home for Disabled Persons. I'm just going to call it the Disability Office. So its official role in statute is to put into action the trajectory of a disabled person towards the compensation of their loss of autonomy. So these disability offices promised a one-stop shop for disabled people to access all sorts of services and benefits. And this part of my talk is really motivated by the classic insight from Michael Lipsky, which is that the actions of street-level bureaucrats in aggregate on the ground are what really makes up social policy. And at ground level, I'm going to show that this effort to make exist a new population ran into all sorts of unexpected bureaucratic hurdles. So here's how this was supposed to work. So a person with a mental disorder goes to get treatment in the public sector. When psychiatrists treat them, they will also identify a subset of patients, like those with very serious schizophrenia or bipolar disorder, who need additional supports with housing, employment, or income. If so, the social workers in the sectors will apply to the disability office. And the disability office then makes an evaluation. They can directly grant something like a minimum income, the allocation for handicapped adults, or authorize them to receive services like an employment retraining program, a team focused on helping people with activities in daily life or housing. Again, this was meant to really be a transformation of bureaucratic kinds, which is that malades could also be disabled people thanks to this idea of psychic handicap. That is, that a mental illness can also cause a disability. So in the ethnographic anecdotes, you're going to see disability determinations are made by a pluridisciplinary team that includes doctors, psychologists, and employment specialists. As you can see from this image provided by the state, they are always smiling and they love their jobs. They use three pieces of information. So first, a doctor must provide a medical certificate. But far more important was that there needed to be an expert evaluation of somebody's limitations to their autonomy. And these decisions are supposed to consider someone's life project. That is their own vision for how the disability system could support them meeting their goals. Most people you're going to see are evaluated exclusively based on their paperwork. They're not present, although some could be interviewed. What I'm going to show, though, is that in practice, disability evaluators struggled with a mismatch. You will see several contradictions between the characteristics of the malades who are being sent to them by the health system and their pre-existing typology of what a disabled person was, how they relate to the state, and the kind of challenges they would face. Before I get to the difficulties, though, I want to emphasize that there are some kinds of demands that the disability office could very swiftly dispatch. Consider the following case of a 38-year-old woman from Senegal. I want to quickly comment that in instances where I didn't actually see the applicant, I can only infer race based on comments about their national origin and what French-born applicants, there's kind of the unmarked categories. So it's this data is fragmentary, but I think it's worth considering. So here, the head evaluator is reading this woman's life project. The woman says, "I would like to have stable employment, to marry, and to have children." And the psychologist sort of makes a off-the-cuff remark saying, well, she's running out of time for children. The doctor, and this is not a doctor, the psychiatrist, this is a doctor who works in the disability office, says, well, she was hospitalized in 2011 for schizoaffective disorder. She's now stabilized on an injectable antipsychotic. The evaluator says, that's good. And the doctor says, yes, but she's chronically delirious. She hasn't worked in years. An employment specialist cuts in to say she had little short-term contracts here and there. She always gets fired for persistent absenteeism. When we last saw her, she wanted to work at a daycare, which seems not adapted. Now she's saying she's hoping to start a business selling specialized hair products. And the head evaluator says, let's give her the allocation. This is the disability income for 5 years. This is not something that's going to get better. And she turned to me saying, it's better for her, maybe not for the state, which is to say it's very, very expensive. On one hand, we can see some of the moral judgments that we expect from bureaucratic decision-making, including a somewhat veiled reference to race and a joke about the woman's desire to have children. However, ultimately, the team decided to give this woman a minimum income for an extended period of time with no one insisting that they force this woman to continue to try to find work. This is actually somewhat surprising to me as somebody from the US, where people with mental illness receiving Social Security benefits have been the subject of endless attempts to purge them from disability roles. Yet for my informants in France, being a malade with a serious psychiatric illness created a kind of presumptive deservingness of some level of solidarity. When we look at benefits other than the allocation, again, this minimum disability income, we see more problems emerge. So I joined Clémence, a psychologist at the office, for an information gathering interview. The applicant is a 23-year-old second-generation African migrant and just out of a 3-week involuntary hospitalization. His psychiatrist appeared to have filled in the application for him and applied for basically everything that the office offers. When he came in, he appeared to be, both very demoralized and heavily medicated. Clemence opened with a question that, given that the disability office is sort of supposed to focus on people's life projects, seemed like a bad sign. She said, "Do you know why you're here today?" And he said, "Not really." She went on, "Well, you're here because I want to learn a little bit about the difficulties you feel, the things that bother you, the things that are blocking your return to social and professional activities. I feel isolated. Okay, let's talk about that. What do you do beyond going to the clinic?" "I lift weights, but I stopped." And he kind of, didn't add anything. Clemence tried to dig deeper to understand the man's difficulties. She said, "Okay, now I'm going to ask you about your autonomy. How are you with getting ready in the morning?" "Ça va, it's okay." And she asked a series of questions about activities in daily life and always got the same 2-word answer. "Are you feeling anxious?" "Maybe." "How about depressed?" "A little." The psychologist closed saying, "Well, it actually seems like you don't have a lot of complaints right now, so I'm trying to figure out what kind of employment supports would be useful for you." Ultimately, after the interview, I asked Clemence what she could do, and she told me, well, he's in denial. He hasn't accepted that he has an illness that is chronic, that will be there his whole life. He has a heavy disability, but we have to reject him for employment supports because he's not willing to provide the kind of information the state needs. Let's see. This individual's lack of self-advocacy was problematic because it was at odds with what was expected from the bureaucratic kind of disability. To reiterate, under the new disability system created in 2005, disabled people were supposed to take the lead in their own applications. You can see here a part of the application that asks the user to elaborate their situations, expectations, and projects for daily life. For the social workers in the sectors that I observed, though, this idea that malades could come up with a life project was inconsistent with their own experiences. As one told me, "I pretty much only do disability demands for people who don't think they're disabled. It's completely paralyzing to ask them what their life project is. Often it's just survive with 800 euros a month. That's the allocation. And so we just leave that blank. What's the point in writing be in care and eat as a project?" What this social worker sees as an inherent feature of mental illness, however, could arguably be seen as a product of psychiatric care itself, which focused on rendering patients compliant and largely passive. In other instances, people who did appear to take initiative to apply for benefits applied for things that seemed out of sync with their actual state. Here, the team considers a 44-year-old North African man. Head evaluator says he's a paranoid schizophrenic, psychotic, and not stabilized. He has apragmatism, which is a lack of initiative, disassociation, and incoherent ideas. The psychologist says, looking at the list of his medications, he's got to be a zombie. The head evaluator notes, right, his doctor is saying that he has a hard time bathing and he needs help in daily life. He's a good candidate for the benefit for the compensation of handicap, which is a really generous welfare benefit, can pay up to 12,000 euros a month for help in daily life. So this is something that if he applied for, it could potentially be quite significant in his life. Nonetheless, the psychologist says, unfortunately, he crossed that out. He wants help with employment. The doctor says, no way, the certificate says he's in complete denial of his pathology. How can he be asking to work? And the head evaluator concludes, all we can say is he still needs medical care, give him the allocation for 5 years, reject everything else, and that's it. In short, applicants were engaging with the disability office in line with the expectations of the bureaucratic kind malade. That is, they're often delusional seeming people who need professionals to tell them what to do, rather than the bureaucratic kind disabled, which after the 2005 reform was supposed to mean people who could accurately identify their needs themselves. So the evaluation team at the disability office was expected both to pay attention to the subjective desires of applicants and also their objective limitations. Disability benefits are expensive, and the state expected evaluators to carefully document the limitations in everyday life that justified them. Yet what was an objective problem could be hard to pin down. So in one case, I viewed a redacted medical certificate where the psychiatrist wrote that the person had paranoid schizophrenia since 1996. To our surprise, though, you can see at the bottom, the psychiatrist wrote that this person could accomplish all their activities of daily life without difficulty. And in some ways, compared to a person in a wheelchair who was blind, this was in some sense true. At issue with the difference between disabilities that resulted from a flat incapacity to do certain activities versus an inexplicable unwillingness to do it. So as one family advocate commented to me, the problem is that people with psychic handicaps can physically get up, they can dress themselves, they can prepare food, but their illness means that sometimes they don't do it, and no one knows how to evaluate that. Secondary issue here was differences in what sociologist Neil Gong calls the social prognosis of these individuals. That is the kinds of lives we imagine people as capable of living and the way they differed between people with mental illness and those with disabilities. So one evaluator told me, this is a disability evaluator, said, once we did a visit to the home of somebody whose psychiatrist said she was autonomous in everything and just needed some income. We discovered that all she ate, breakfast, lunch, and dinner, were cans of sauerkraut. For the nurse from the psychiatric clinic, that was fine. At least she's eating. But for us, it was like, maybe this person could use help making better choices. Once again, for the bureaucratic kind malade, eating exclusively sauerkraut was considered a success in the eyes of a psychiatrist, but it was far below the bar for what was expected for a person with disabilities post-2005. So my quantitative coding led some credence to these interpretations. The table here is showing the reasoning that was articulated in team meetings I observed where disability evaluators decided to turn people down for some benefit that they applied for. As you can see, that evaluators rarely concluded that people with mental illness were insufficiently impaired to merit benefits, which they often did, as you can see on the right, for people with other kinds of disabilities. Instead, they more frequently claimed they simply didn't have enough information to know, tied to both people's struggles to self-advocate and the difficulty of objectifying psychiatric conditions. But the most frequent argument they used was that people with mental illness could not enter the disability system because they were still in treatment, which is effectively a rejection of the very principle of the 2005 law, which is that you could be a patient and a person with a disability at the same time. So here the team debated a woman with psychosis who was asking for an expensive retraining to help her fulfill a life project of moving from a now defunct career in sales towards one as an administrative assistant. The employment specialist said, I saw her at the agency a few weeks ago and she was clearly delirious. So this raised the question, is this someone who can work? The doctor says, the medical certificate says chronic psychosis, but not much else. She goes to the sector clinic once a month and needs to work to occupy herself. But the certificate is 1.5 years old and a lot can happen in that time. The employment specialist says, well, we need to know what the psychiatrist is even talking about. The person I saw is not somebody I can send to a professional retraining. And again, the head evaluator concludes, this one is easy. We tell her she's still in care, right? That she's not conscious of her situation, and that's incompatible with a retraining. There's some fluctuating preferences could be as complicated as fluctuating symptoms when it came to finding employment. So a 42-year-old man with an undergraduate degree in applied math, whose schizophrenia had been stabilized for over a year, seemed like a decent candidate. So here the employment specialist said, but his problem is he can't decide his professional project. In 2011, he was working on a training to become an electrician, but he said it was too manual. I don't even know what to do with him. The head evaluator said, okay, concretely, do you think he's going to find work in the ordinary milieu or should he go to the protected sector? Protected employment would be a sheltered employment with only other people with disabilities and a lot of supports on site. And the specialist says, he didn't check that box on the application and it's not worth talking to him about it. Doctor then says, well, a psychiatrist is writing that he'd like to be a conflict mediator or a monitor in a school. How is this even possible? There's kind of an assumption that those are not appropriate careers for somebody with bipolar disorder. Head evaluator says, well, maybe we can help him develop a clearer project, come up with a different idea of what he wants to do. And the employment specialist, again, here is kind of dismissive and says he's not going to succeed. He won't finish anything. And he'll come back to us and we're going to have to start everything again. France's employment supports for disabled people rests on the idea that somebody can follow a long-term trajectory that might include working on a professional project, taking a training, having an internship, and only then actually looking for a job. All of this was predicated on the idea that somebody's disability and their desires would be stable. But the very nature of a chronic illness is that it fluctuates in a way that created a mismatch with this step-by-step approach. These examples speak to a strong cultural cleavage in France. So the state has long focused on employment for disabled people through a pretty robust range of policy levers, like a 6% quota for disabled workers in all large employers. Overall, you can see on the right that far fewer adults receive a disability income on the basis of psychiatric condition in France than the US. On the other hand, the French welfare system also gives extensive protections from the need to work for sick people, as you can see for the data on people for long-term sick leave. And the US obviously has no equivalent to that because we can't have nice things. But in any case, you really see this cultural cleavage here, that to be disabled actually largely means to go to work, and to be sick means to stop working. Surprisingly, many French professionals believed that their job was to protect mentally ill people from the risks of a difficult job market. So one told me, people are coming 48 hours after they've been discharged from the hospital and saying, I want to work. And we are there to detect if they're just saying, I need to exist socially or I need to get out of this house. Our goal is to help people realize that there are things that are just no longer possible. We operate based on the principle of reality. We don't want to mobilize people towards something they should be grieving. In these cases, protection from illness via psychiatric care once again trumped the pursuit of autonomy in a disability system. Well, I've so far talked mostly about applicants who are trying to seize on the autonomy promoting opportunities of paid employment. Another part of the work of the Disability Office was to get people out of the autonomy destroying situation of a long-term psychiatric hospitalization. And this often meant moving people into specialized residencies for disabled people. These are also institutions, but they differed in really significant ways. So unlike hospital patients, residents have a key to their own room and they can come and go as they please. The state has a huge interest in making these transfers. So first, a hospitalization costs nearly €1,000 a day, while these institutions cost more like 200. Most importantly, the fact that many people with disabilities, in the iconic case in France is people with autism, are inappropriately placed in hospitals or in some cases sent to Belgium for lack of a place in France has been the object of repeated scandals and many government initiatives to get people out of these situations. Nonetheless, once again, there was a challenge that was related to the structure of the welfare state. Psychiatric hospitals and sectors more broadly are public institutions that are obligated to treat everyone who is sent their way. These disability institutions, on the other hand, are nonprofits that can select which of the people sent to them by the disability office they would actually take. And they were largely looking for people with profiles that were similar to their archetypes of a disabled person with a physical impairment or developmental limitation. So here, a social worker in the sector where I conducted my observations told me we had a patient with a 3-year hospitalization. He would collect cigarette butts and eat them and drink hand lotion. We found a place for him in a nursing home, but they sent him back to us saying he wasn't willing to participate in group activities. He just wanted to eat cigarette butts. I spent a lot of time selling our patients, and the institutions say, we don't want people with behavioral troubles. And I'm like, that is the definition of our population. Again, though, what the sector psychiatrists saw as a failure of the disability system to take into account the nature of chronic illness, the disability system saw as a problem with the way sectors were fabricating certain kinds of people who could not be placed in the bureaucratic kind of disability. So this is a quote from the head evaluator in the disability office who was responsible for refining residential placements. He told me, look, in psychiatry at the hospital, you're in your room, you wake up at a precise hour, you take your treatment, you have breakfast, and then you wait. Maybe once or twice a week you have an activity, but the rest of the time, absolutely nothing happens. You stare at the ceiling. So you're not at all ready to restart a social life, even in an establishment for people with disabilities. In the hospital, everything has arrived for you. When you arrive in a housing program for disabled people, you need to get yourself up, live collectively, activities in the morning and afternoon. And if you're not prepared, it's exhausting. So that creates behavioral troubles, frustration, incomprehension, and so you go back to the hospital. So in summary, this project of making people with mental illness into people with disabilities was not stymied by a lack of political will or an absence of what Bourdieu called moral conformity. Instead, it stemmed from the logical contradictions between the way the state had defined being a malade and being a disabled person. So malades were presumed unable to recognize their illness, while disabled people were supposed to actively seek compensation for their limitations via life project. Malades were largely tried to avoid labels, whether it was being ill or disabled, but the 2005 law envisioned disability as a valorized identity that people would actively assume. These difficulties were created by the difficulties created by chronic mental illnesses were difficult to objectify because they were at the level of volition. Someone with Down syndrome or in a wheelchair, on the other hand, was expected to have measurable limitations that could be found in a physical exam or an IQ test. And finally, employment programs struggled with malades' fluctuating limitations, which differed from the stable limitations assumed by the disability system. These are profound contradictions that are difficult to bridge. It is difficult for the state to see the same people through such different optics. But even more importantly, the challenge was that people had been turned into malades by a healthcare system, and then they arrived in the disability system with these characteristics, which made them, in the eyes of evaluators, incompatible with the bureaucratic kind of disabled. So I'm not going to go into full detail the way these ground level difficulties looped back, but with the benefit of several years of distance, I'm able to see how both the structure of the French welfare state and the meaning of the key categories I've presented shifted over time. So for example, in the 2016 National Strategy around Disability, the state moved to defining psychic handicap for the first time as a risk to be avoided. One ministry official told me, our idea is to avoid chronicity and handicap. That's what maximizes autonomy, to prevent a handicap. This probably seems intuitive, but it was a significant reframing of a category that advocates had initially envisioned as empowering. Rather than trying to get the state to see double, increasingly money has been flowing back into the health system to allow medical teams to set up disability-style services, for example, by providing housing or greater accompaniment in acts of daily life. In many ways, they are returning to the original idea of integrated services under sectorization, but with a stronger mandate to promote autonomy. And finally, many programs were eliminating expectations of a self-identification to gain access to services, which was so core to the way the disability office thought about this. So as one ministry official reflected, this rejection of the label disabled person by malades, it's very strong. And yet to benefit from our policies of accompaniment in housing and employment, you have to have this label. New public policies were working around this the expectation of a formal categorization by the disability office to benefit from services. All of these examples I've argued are examples of how the clash between the bureaucratic categories of malade and disabled circled back to change the nature of the programs that administering those bureaucratic kinds. This is not intended to be a functionalist story about how policy mechanically adapts, but instead it's about the ways that states are always playing catch up with the human consequences that their own policy decisions have created. So a few conclusions. So my use of this idea of looping calls attention to how we need to look at not just policies themselves or how they are implemented by street-level bureaucrats, but the unpredictable impacts of how people respond to them. Even projects with widespread support can be limited by these kind of logical contradictions created by the past ways that states constitute populations. Resistance can come in the form of overt mobilization or simply people not engaging with programs in the way that designers expect. People with mental illness in France have been very little mobilized by movements like anti-psychiatry, but they nonetheless force changes in the project of reclassifying them as having psychic handicaps. In terms of street-level bureaucracy, literature from scholars like Armando Lara Milan or Josh Syme emphasizes the constant interprofessional conflict and fragmentation as different state agencies try to shove unwanted clients onto each other. However, when we look comparatively, we can see how different bureaucratic kinds can link together bureaucratic decision-making across contexts. In France, disability bureaucrats, or as they show in part 3 of my book, judges and lawyers, they might have their own conceptions of people with severe mental illness, but they all have to contend with the characteristics of malades as they have been imposed on that population by the public psychiatric system. And finally, while I've spoken very little about the experiences of people with mental illnesses themselves, the impact of these decisions on their institutional trajectories are weighty. The nature of mental health treatment and the formal diagnostic categories that are used have converged across national boundaries. But it is very different to take those medications in a hospital versus a prison, and to have those diagnoses imposed on you by a psychiatrist who claims to be responsible for organizing your entire life, as in France, versus one stop on an institutional runaround between clinics, shelters, ERs, and jails, as in the US. On that note, I will thank you very much for your attention, and I would love to hear any feedback or questions.